We'll now discuss on arthritis. By the way, this lecture is sponsored by Dutch Mill. So for arthritis, what we do is we search patterns to know what type of arthritis is seen in our patients. So we look at the alignment of the joint spaces, the bone density, if it's increased, decreased, or no change, the cartilage spaces, if there are calcifications um, seen within these regions, and also the distribution. This is particularly important since certain arthritis will have a predilection for certain parts of the body. So first, let's tackle the degenerative joint disease. So this is also known as your osteodegenerative changes or osteoarthritis. And it has a triad. So remember this triad by heart since this is the most common arthritis that we see, and these findings will almost always be present. So first and most importantly, you need to have joint space narrowing. So this is the right shoulder joint. There is narrowing of the glenoid fossa, more on the inferior aspect. So you can see that this region is markedly narrow relative to the superior aspect. Sclerosis or end-plate sclerosis usually happens at the margins. So observe that this part of the bone is much more denser than this region. So that's sclerotic changes. And you have osteophytosis or osteophyte formation. So these are bone outgrowths seen usually at the margins of the affected joints. So in this example, you have osteophyte formation here and as well as here. It's not so pronounced in this superior aspect. Again, since the more affected portion is the inferior region. Now for DISH or diffuse idiopathic skeletal hyperostosis, it presents with osteophyte formation and usually it's much more pronounced. And in this example, they're actually bridging, meaning they're combining with the next vertebral body. But in dish, you won't be able to appreciate this space narrowing. So relatively, the these spaces are preserved, and the sclerotic changes are not seen in these cases. It's really just formation of osteophytes. So for osteoarthritis, again, it's the most common. So again, this is another example, this time affecting the hands. So you can see that there's marked narrowing of the interphalangeal joint spaces and there's increased density along the margin, so that pertains to your sclerosis. And you have again spur formation or bone outgrowths along the periphery of the involved joints. So this is what you call also the Gallowing sign. Here's another example of osteoarthritis. Now, sometimes there are certain cases in which erosions also develop in osteoarthritis. So we need to look out for these locations. They are particularly the TMJ, the sacroiliac joints, the acromioclavicular joints, and the symphysis pubis. So erosions can be part of the um, radiologic changes. It's important to note because erosions can present in other forms of arthritis. However, if they present with erosions in this particular joints, you can say that the findings could be more attributed to osteoarthritis than as to the other arthritis. So here are some of those erosive changes. And you have marked narrowing of the sacroiliac joints. Again, compare this portion with this one, the superior aspect. Here, the joint is fairly wide, and you don't see the sclerotic changes along the margins. As compared here, wherein you have those very dense regions which suggest sclerotic changes, and then you have some erosions within the narrowed sacroiliac joint. Geodes or subchondral cysts can also be seen in cases of osteoarthritis. So basically, they are geographic cystic lesions seen near the joint spaces. Your clue would be that the adjacent joints will show features of osteoarthritis. So that will help also your diagnosis that it's just a geode and not those other cystic bone lesions that we described in the previous lecture. Next is rheumatoid arthritis. So for rheumatoid arthritis, it also has several key findings. So let's go to them one by one. First, soft tissue swelling, then we have osteoporosis, joint space narrowing, marginal erosions. It has a proximal distribution, and it's usually bilateral and symmetric. Now, osteoarthritis may not be symmetric, and it doesn't usually present with erosions except for certain areas. Joint space narrowing is consistent more or less in all arthritis. Now, what's key is that there is osteoporosis and also there is soft tissue swelling. And usually these patients also may present with severe pain. And the osteoporosis in RA is more of peri articular in location, so meaning near the joints. So this is an example. You can see that more or less the destruction in both hands are more or less the same. So you see this increased lucency. This is your osteoporotic changes, decreased bone density, and thinning of the cortices. Soft tissue swelling in this case is not so evident. You also have erosive changes here. Again, it's more or less symmetric. You also have some erosive changes here in the first metacarpophalangeal joint. Again, you have geographic osteoporosis, and it's seen on both sides. For rheumatoid arthritis of the hip, it typically presents with axial narrowing of the joint space, meaning the femoral head will push towards the acetabular fossa in more or less with the same angle of the femoral head, as opposed to osteoarthritis of the hip, wherein the migration of the femoral head is more superior. So the involved region of the narrowing would be um, much more limited towards the lateral aspect. If you compare it to this case, wherein it's more um, encompassing and extends towards the almost to, involving the entire clear space. Rheumatoid arthritis of the shoulder can also present as such. So you have narrowing, again erosions, and decreased bone density in this area. Another thing to take note of is that this arthritis could occur in conjunction with one another. So this is an example of osteoarthritis occurring together with rheumatoid arthritis. So you'll see a combination of the features, what is distinctive and why we can say that there is osteoarthritis aside from rheumatoid arthritis is the marked narrowing of the clear space, the knee clear space, as well as the evident sclerotic changes along the medial aspect of the knee joint. Remember that in osteoarthritis, the medial compartment of the knee is much more involved than the lateral compartment. Next up, we have the HLA-B27 spondyloarthropathies. So it includes the following: ankylosing spondylitis, inflammatory bowel disease, psoriatic arthritis, and Reiter syndrome. So I had to fix the slide for typos. Um, the characteristics of these spondyloarthropathies is you have bony ankylosis, proliferative new bone formation, and usually it's usually axial involvement. So when we say syndesmophyte formation, this is similar to your uh, osteophytes. However, the growth is in a vertical fashion. So it's going from top to bottom or bottom to top, as opposed to osteophytes, wherein it's more of horizontal. So the growth will be here towards here if it's osteophytes. If it's syndesmophytes, it will go to go up or down. And usually it will lead to what you know as the bamboo spine deformity of ankylosing spondylitis. So it's flowing syndesmophyte formation, and you can see that the ends of the um, vertebral bodies appear to be connected. For psoriatic arthritis, um, patients will develop this what we call as proliferative erosions. So again, these are erosive changes with which is somehow mixed with periosteal reactions. So it's very much irregular. So it appears to be that there is new bone formation, while at the same time there is bone resorption. And eventually it will lead to ankylosis also, meaning the bones will be connected and there's total loss of the joint spaces. So what happens is the patient will be unable to move those joints. In Reiter syndrome, it can also affect um, the calcaneus. In this case, there's development of a calcaneal spur. So this is not the typical calcaneal spur that we see in other cases of degenerative changes or calcific tendinitis. So the shape is much more irregular, and this is usually seen in Reiter syndrome. We can also have, again, this irregular fluffy periostitis along the medial aspect of the first digit, and we have associated soft tissue swelling. So this can be attributed to Reiter syndrome or psoriatic arthritis. Next, we have gout. For gout, uh, these are the clues. We have well-defined erosions, and these erosions will have sclerotic margins. Other name for this is your rat bite erosions. Then in the advanced stages, you have your soft tissue nodules, or what we popularly or more familiarly we know as tophies. And the distribution is random, so it's not symmetrical like in rheumatoid arthritis, and also there's no osteoporosis. Again, just like in rheumatoid arthritis, wherein there is osteoporosis. So those are the things that you look for to differentiate the two. And this example is a classic example of gouty arthritis. The soft tissue nodules have beginning cloud-like calcifications already. And these are your rat bite erosions. Note the sclerotic margins in these erosive changes. And again, the distribution is random. You can see that also that the bone density is relatively preserved. Again, this is a typical rat bite erosion, sclerotic margin, and we have joint space narrowing. No osteoporosis, no sclerot and plate sclerosis, as seen in osteoarthritis. You don't also see osteophyte formation along the margins. So what's there is you have erosions. Here also you have erosive changes. So these are all features of gout. You can also have pseudo gout or your CPPD, and it has a classic triad of pain, cartilage calcification, and features of degenerative joint disease. Now, the other name for cartilage calcification is your chondrocalcinosis, as shown in the arrows. So you will appreciate this as calcifications. They're usually horizontal and they are seen within the um, joint space. So instead of seeing a thoroughly black joint space, there are some areas in which calcifications will develop, and they correspond to the cartilages of your knees. So here's another example of chondrocalcinosis in the second metacarpophalangeal joint. So that's here. So your clue is that these areas don't usually have calcifications or bones. You don't expect to see them. And usually these calcifications are more or less linear or rice grain in appearance. So they're just elongated. And again, you look for the clinical history since these patients will present with much pain at the specific sites where the calcifications are seen. For collagen vascular diseases, first we look at SLE. So in SLE, what we see is soft tissue wasting and osteoporosis as seen in this patient. Aside from that, you also have ulnar deviation of the phalanges. So these are the hallmarks of SLE. For scleroderma, again, we have soft tissue wasting and osteoporosis, and there there are some scattered calcifications in both hands. In hemochromatosis, This is a disease of excess iron deposition. So what happens is similar to the radiographic findings of degenerative joint disease. So you have end plate sclerosis, joint space narrowing, and um, some degree of spur formation, although not as pronounced in this case. And usually the joints affected are the second to fourth metacarpophalangeal joint, as seen in this case. We have much more pronounced sclerotic changes as compared to the fifth digit. The other name of Charcot joint is neuropathic osteoarthropathy, and it's usually seen in diabetic foot patients also. Next, we look at joint effusion. So the clue to joint effusion usually is thickening of the um, interfat pad space, and if it's in the knee, usually the suprapatellar fat pad is markedly thickened, and usually if it measures more than 1 cm, you're confident to diagnose knee joint effusion. And usually it happens when there are occult fractures, could be from the knee or from the patellas in this example. So you can see this cortical discontinuities compatible with a fracture in the patella. Now for avascular necrosis, this one is, or what this is what we also call as osteonecrosis or aseptic necrosis. So it's usually due to reduced or completely interrupted blood supply to bone with death of the cellular elements. So the typical appearance would be a bone that is um, much more smaller to its normal counterparts and with increased density. So in AVN, the earliest sign is joint effusion. So that could manifest as soft tissue swelling or could just be a very subtle lucency. Sometimes it's not even seen that we only see it in the follow-up radiograph. So for example, in this case, the only finding that we have is patchy sclerosis in this area. That's not really very obvious. Os- Vascular necrosis also has different names in different body parts. For example, in Kenbox, Malaysia, it involves the lunate. So you can see that the lunate bone is much more dense and flattened in shape. So basically, it's just a vascular necrosis of the lunate bone. Another example would be your Coller's disease. This time, this involves the tarsal navicular, it's pointed by the arrow. So there, again, there's flattening of the involved bone, and it's much in, increased density relative to the adjacent bones. In a vascular necrosis of the spine, it's called Schurman's disease. So usually it involves the apophyseal rings of the vertebral body. It will manifest as painful kyphosis, and usually there are multiple vertebral involvement. So that's my last example for um, vascular necrosis. For the arthritis, what's important is to familiarize yourself with the three most common entities, which are osteoarthritis, rheumatoid arthritis, and gouty arthritis. And remember that the features may have overlap, But what's important is that you're able to identify which one is more evident or more suited in your case. And usually, all of these cases will have joint space narrowing. So you have to look at the other features to help you diagnose these cases. For osteoarthritis, since it's also known as degenerative, so it's common with old age. It can also present, these patients will also have osteopenia or osteoporosis. So that means it could also overlap with rheumatoid arthritis. That's why you have to be careful also to look for the other signs of rheumatoid arthritis and help help yourself rule out if it's present or not. And you also have to look at the other clinical parameters. If it's really if you're really dealing with rheumatoid arthritis or gouty arthritis, there are certain laboratory tests that will help you reach those diagnoses. The radiographic findings are just add-ons, or they will just help you augment your diagnosis.